Welcome back to this session in pharmacology where we look at drugs affecting the cardiovascular system. There are many cardiovascular diseases. We're going to concentrate on what you will see more commonly in your clinic. Perhaps blood pressure and angina, and certainly people who have high lipid profiles in their blood. So we'll look at blood pressure, angina and hyperlipidemia, then we'll look at antihypertensive drugs, anti-anginal drugs and lipid-lowering drugs from a Western pharmaceutical viewpoint. Cardiovascular disease encompasses heart attacks or myocardial infarcts, stroke and various other blood vessel diseases. There are interrelationships between these. Some of the major risk factors for cardiovascular disease include hypertension, cigarette smoking, obesity, where a person might have a body mass index of greater than 30 kilograms per metre squared of body surface area. They may be physically inactive, but they could have a high lipid profile. It may be due to diet and it may be due to genetic influences. Similarly, diabetes mellitus contributes to a lot of blood vessel diseases. We'll see that kidney and kidney disorders and dysfunctions will also be major risk factors. So a person who shows microalbuminuria is at risk of cardiovascular disease if they have an estimated glomerular filtration rate of less than 60 millilitres per minute. This can also increase their risk factor for cardiovascular diseases. There are a lot of genetic interplays, but in general, estrogen is protective for women, and their risk of cardiovascular disease does not increase until after about the age of 65. Whereas for men, their risk is, once again, age, but generally after the age of about 55, their risk of cardiovascular disease increases. But there are some people, perhaps due to genetic influences, that have a family history of premature cardiovascular disease. It's important to identify these people in your clientele from their family history. It is where there would be family members who have shown cardiovascular disease before the age of 55 if they were male, or before the age of 65 years if they were female. So then to have a look at hypertension, the physiology of blood pressure, and then the causes and contributing factors that lead to a high blood pressure. There are two main parameters to measure when looking at arterial blood pressure. First of all, there is cardiac output. The left ventricle ejects a certain volume of blood per a given unit of time. You measure this cardiac output and then multiply it by the total peripheral resistance. Peripheral resistance is just that natural resistance to the flow of blood as it moves through the blood vessels. The two factors together, cardiac output and total peripheral resistance, the major parameters determining blood pressure. And so when we look at hypertension, we'll see it's a very complex pattern. Many factors that can affect either cardiac output, total peripheral resistance, or both factors. So between the heartbeats, there's a certain pressure on the major arteries, the diastolic blood pressure, and of course as the heart beats, the systolic blood pressure. And we're going to see that as far as the National Heart Foundation is concerned, it suggests that the systolic blood pressure needs to be known over a period of time and can therefore be this strong, consistent predictor of people at risk of cardiovascular events such as a stroke if that systolic blood pressure is consistently high. The National Heart Foundation regularly reviews its population data on the basis of any studies that may have been done on populations, looking at the risk factors for all Australians. Currently, using the 2008 published figures, Normal blood pressure is deemed to be a reading of less than 120 millimeters of mercury for the systolic pressure and a reading of less than 80 millimeters of mercury for the diastolic pressure. In perambulatory people, it is quite common then to have readings above that normal cutoff, but this would be deemed high normal if that reading was between 120 to 139 millimeters of mercury for the systolic and between 85 and 89 millimeters of mercury for the diastolic. Then we'll be more interested in hypertension, whether it's mild, moderate or severe, and lifestyle changes to treat all three forms of hypertension, but then Western pharmaceutical medications that would control any hypertension that was unresponsive to lifestyle changes. A mild hypertension, a grade 1, will be deemed a systolic between 140 to 159 millimeters of mercury and a diastolic of between 90 to 99 millimeters of mercury. The moderate hypertension, 160 to 179 millimeters of mercury for the systolic and 100 to 109 millimeters of mercury for the diastolic. So this uses statistical parameters to set those ranges. A grade 3 or severe hypertension will be any reading of above 180 millimeters of mercury or above 110 millimeters of mercury for the diastolic. In many cases, it cannot be pinpointed to just one cause. The majority of cases are like this, so the majority of hypertension is deemed to be primary or essential, some unknown cause. It is possible to have a high blood pressure and to show no symptoms as yet, but this is still a major risk factor for the development of a stroke or other cardiovascular disorder in the future, and so needs to be identified by either the client or by their healthcare practitioners, including GPs. Important then to identify that hypertension and to put in place lifestyle factors to control it. The risks of thrombosis, cardiac failure, renal failure, damage to the retina and the optic nerve, damage to peripheral tissues, fingers, toes, ongoing damage to small blood vessels and then later major blood vessels, and the risk of cerebral hemorrhage make it imperative that once identified, a person with a hypertension tries to control it. So for you as healthcare practitioners, the aim is to identify those people with hypertension and to begin a treatment regimen, to monitor it, and if it is not being controlled by those changes, which would include lifestyle changes, important to refer to a general practitioner so that Western pharmaceutical treatments can be tried. The aim being to prevent some of these other very serious complications of hypertension. As a disease burden on society, hypertension is associated with a very high morbidity and a high mortality, once again making it imperative for you as a natural health practitioner to address national health issues and to play your part in helping treat hypertension. But it is a complex cycle. We'll look at one of the important parameters, the peripheral resistance, and some of the physiological factors that impinge upon this. Anything that constricts the arterioles will increase peripheral resistance. We're going to see then that the sympathetic nervous system and its innervation of those peripheral arterioles is quite important. Various receptors lead to vasoconstriction. They include alpha and beta receptors in the vessel walls. In addition, cardiac output is very important, and there are beta receptors in the heart that are then affected, contribute to not only the greater peripheral resistance but can also affect that cardiac output. So we'll see that one of the major Western pharmaceutical targets is those alpha and beta receptors to help control blood pressure. But also very important will be the renin-angiotensin-aldosterone system, the RAAS system, which mediates vasoconstriction. Angiotensin II is one of the most potent vasoconstrictors known. Angiotensin II is made active by an enzyme called ACE, angiotensin converting enzyme. It converts angiotensin I into the more potent vasoconstrictor, angiotensin II. Angiotensin I is also made as an inactive form, a zymogen, angiotensinogen. This inactive form is activated by the kidney in response to renin, which is produced whenever blood pressure is low. So whenever blood pressure is low, it eventually leads to the activation of one of the most potent vasoconstrictors known, angiotensin II. This will then help raise that low blood pressure. In addition, angiotensin II activates another hormone, aldosterone. Aldosterone leads to sodium retention by the kidneys, and water follows. This then increases plasma volume, contributing to raising the blood pressure when it is detected that it is low. But in a person with hypertension, this renin-angiotensin-aldosterone system becomes dysfunctional, and many of the drugs that try to lower blood pressure work at this level of the physiology. Now, interestingly, when we go and look at some of the drugs, we'll look at angiotensin converting enzyme inhibitors, drugs that target a particular protein, that enzyme. We'll also look at some drugs that block the way angiotensin II binds to its receptor at the arteriole and other major blood vessel wall, blocking the action of angiotensin II and thereby blocking that vasoconstriction. And we'll look at the adverse effects of various drugs. Now, with the angiotensin converting enzyme inhibitors, we're going to see a very interesting adverse effect, a cough that is produced because this same enzyme active in the lungs produces other physiological effects, and the drugs that inhibit that enzyme then produce various adverse effects in the lungs, including this cough. So before we look at drugs that target either the alpha or beta receptors or anywhere within the renin-angiotensin-aldosterone system, it is important to stress that for any client, even one with a severe hypertension, it is critical that they also implement various non-pharmacological measures to bring down their hypertension. If they are obese or overweight, it's critical that they lose weight. If the person has a high intake of alcohol, that it be reduced. For all clients, important that they limit their dietary sodium intake. As you've seen, the effects of sodium on water retention being quite critical in controlling blood pressure, and so when it is dysfunctional, controlling the amount of sodium in the diet will then limit that sodium retention by the kidneys. Similarly, for all clients, it would be important to put them on a system of physical activity that would be consistent with their age, their weight, any other concomitant disorders that they have. So it might be Tai Chi, yoga, perhaps swimming, walking, or various other physical activities to not only help with the weight control, but as we've seen, just using normal body physiology, the nitrogen monoxide production that occurs whenever shear forces are put onto blood vessels, the major blood vessels, and how that nitrogen monoxide, being a vasodilator, will naturally bring down the person's blood pressure, and when done consistently, exercise can maintain that lower blood pressure. So in various ways, get the blood vessels to relax, reduce the blood volume, have less sodium retention, so less dysfunctional water retention by the kidneys, or perhaps increase cardiac output during exercise, getting cardiac muscle more active so that during exercise and even normal activity, less cardio contraction is actually needed to produce the same cardiac output. All of these factors will then contribute to controlling that person's hypertension. And for some people, they respond very well to these lifestyle changes and don't need any further natural or Western pharmaceutical preparations. The drug therapy, though, if it is needed, will include diuretics. We'll see beta blockers, this time perhaps not working so much on the heart as on the receptors for adrenaline, on the larger blood vessels and on the arterioles. But those ACE inhibitors that we mentioned, angiotensin converting enzyme inhibitors. Then there are those drugs that target the most potent vasoconstrictor, that angiotensin 2. We want to block that action, so these drugs are antagonists at that receptor, angiotensin 2 receptor antagonists. And then we'll also consider calcium channel blockers. There are others, alpha blockers, hydralazine, and various centrally acting drugs, so that there are a range of medications used in treating hypertension. And it would be important then for your clients during your case history taking to find out what medications they were on, and because there is such a vast range, to then go and research what types of antihypertensive drugs this person may be on. And we'll see that many times combinations of drugs are needed. So it's a very complex picture of many different drugs working at many different centres. We won't have time to look in a great amount of detail at the centrally acting drugs, but they are generally working at adrenergic receptors in the CNS. So we've given a couple of examples there, clonidine and methyldopa. What we will concentrate on looking at are the diuretics, which will include thiazides, drugs that decrease sodium retention by the kidney and therefore encourage excretion of water and decreasing blood volume. This eventually leads to less constriction on the blood vessels and then helps to control that person's hypertension. But there are various other physiological effects, such as various baroreceptors that are found in the carotid sinus and in the aortic sinus, that detect changes in blood pressure and send signals to the CNS at the vasomotor centre. So we'll also consider at the level of the heart muscle itself, the receptors, which are mostly, as we said, beta-adrenergic type. So we'll look at drugs that control hypertension by blocking those beta receptors in the heart. We'll be particularly interested in cardioselective drugs, ones that have less adverse effects on beta-2 receptors in the respiratory system. So we'll be looking at metoprolol and atenolol, some cardioselective beta blockers. Note once again the use of OLOL at the end of the name, a consistent generic ending to give you some clues as to the mode of action of these drugs. With the angiotensin converting enzyme inhibitors, once again we'll see that a consistent generic ending is used, the OPRIL or APRIL drugs, captopril and enalapril being two examples of ACE inhibitors. So these were the ones that blocked conversion of angiotensin 1 to angiotensin 2, the more potent vasoconstrictor. And this occurred by actions in the lungs, where that ACE enzyme is found in its highest amounts. Thereby, by having less of this potent vasoconstrictor, this will decrease constriction on major vessels, but mostly those peripheral arterioles, and bring down blood pressure. Because of various adverse effects, we'll discuss the cough that's produced because that ACE enzyme has other effects in the lungs. Various other drugs needed to be developed. We'll talk about the angiotensin 2 antagonists. Once again, note the consistent ending to their name, SARTAN. So irbesartan, losartan, candesartan, and telmisartan, various examples of angiotensin 2 antagonists or angiotensin 2 blocking drugs. With the calcium channel blockers, we'll see once again that they are not only working at smooth muscle, but at cardiac muscle. These calcium channel blockers are chemically diverse, and so there's no consistent ending to their names. We have verapamil and diltiazem as two examples. When it comes to those peripheral blood vessels, we will talk more about the peripheral adrenergic inhibitors than the arteriolar dilators, but hydralazine comes under this category. With the ones that inhibit the actions of adrenaline, we'll look at prazosin, an alpha-1 blocker, and labetalol, which inhibit the actions of adrenaline, as we said, at that alpha-1 adrenergic receptor on smooth muscle, thereby blocking the constriction of those blood vessels, and in this way contributing to blocking the hypertension. First of all, we'll consider the diuretics. We have to consider these because they are the most extensively used drugs, perhaps not just for hypertension, but for other indications, and we'll look at those as well. The indications include anywhere where you want to modify the daily urine production, diuresis. So diuretics will encourage a daily urine production, but it's through renal control of sodium that diuretics control blood pressure, so we're interested in natriuresis as well, the excretion of sodium in the urine. Wherever you can encourage this, more secretion and less reabsorption of sodium, you will encourage water to follow. This will bring down blood volume and treat hypertension. But for a person who also has congestive cardiac failure, CCF, or congestive heart failure, CHF as the acronym may also be given, this will help control any edema associated with that person's failing heart. There are many diuretics that are used in controlling hypertension. They all tend to act at peripheral resistance by decreasing the blood volume. This does have an effect on peripheral resistance. The exact physiological mechanism is unclear, but it is known that the lower the blood volume, the less that peripheral resistance. One of the reasons that diuretics are so commonly prescribed, especially for hypertension, is their efficacy. They are always the first line therapy whether a person has a mild or a moderate hypertension. They can be used alone, but as we'll see, they often lead to less reabsorption of potassium. They are often then used in combination with a potassium-sparing diuretic to control the levels of potassium that are also excreted in the urine. So, often used alone, these diuretics, but in combination with perhaps an ACE inhibitor or a potassium-sparing diuretic. We have to stress, though, that first of all, you try the lifestyle changes. When they don't work, then you make sure your client is referred to a GP for a first-line therapy that still includes modification and changes to their lifestyle while taking those first-line antihypertensives. So as we stressed, because of their mode of action at increasing sodium excretion, reducing sodium reabsorption, thereby affecting plasma volume, definitely cardiac output, but perhaps more importantly peripheral resistance. These are also used in treating edema due to heart failure. There are certain people who have diabetes insipidus. They retain too much body water because of disorders in the kidneys themselves. We'll see that diuretics can also be used to treat their nephrogenic diabetes insipidus. And for various people who are at risk of kidney stone formation, renal calculi, the use of diuretics can produce an environment in the kidneys where there is less likelihood of those calcium deposits and calcium stones to form. We stressed important that the person at the same time, and certainly well before starting pharmaceutical preparations such as a antihypertensive, a diuretic, important that they also lose weight, exercise, and so on. So for this reason, and because of adverse effects of the antihypertensives, important to start the person out on a low dose and only to increase it when it is shown that this is not controlling that person's hypertension. We also said perhaps it might need to be used in conjunction with another antihypertensive or perhaps another diuretic. You can lower the dose of certain diuretics, we'll see thiazides, by using them with an ACE inhibitor. The two have a synergistic effect on the person's hypertension. So instead of them just adding together, you get addition plus a little bit more antihypertensive effect. And so this would need to be decided in working out what antihypertensive regimen to put the person on. There is another type of diuretic called a loop diuretic, which you may find in your clientele being used more commonly for other indications. Loop diuretics also used to treat edema. This might be edema associated with a renal dysfunction or a liver problem such as cirrhosis. There is a disorder called syndrome of inappropriate ADH, SIADH, that's antidiuretic hormone. These people will develop symptoms of diabetes insipidus, retaining water, and these would be treated with loop diuretics to encourage that diuresis and the excretion of that water. Also for people who have very high levels of calcium in the blood, by taking loop diuretics, we'll see that this also affects calcium excretion and reduces calcium reabsorption. But in addition, loop diuretics will also be used to treat hypertension. Oftentimes, we said, diuretics are used in conjunction with a potassium-sparing diuretic because, as we'll see, all the loop diuretics and the thiazide diuretics have this adverse effect of causing excretion of too much potassium. So the potassium-sparing diuretics, not only used as an adjunct in hypertension, might also be used to treat hyperaldosteronism. Aldosterone is metabolized by the liver, so a person who has liver cirrhosis might also need a potassium-sparing diuretic because of its effect on aldosterone and other hormones produced by the adrenal cortex. Potassium-sparing diuretics might also be used to treat hirsutism in females. For example, a person with polycystic ovarian disorder. But the commonest use, as we said, is that adjunct with a loop or a thiazide diuretic for treating hypertension, but it might also be for a person with congestive cardiac failure, where you're treating the edema that results from that failing heart. These people will also lose too much potassium, so the potassium-sparing diuretic might be indicated to block one of the adverse effects of the diuretic that the person is taking. So, to summarise all of the diuretics and their actions, very important that you do go back and review the nephron and its physiology, the glomerulus and the Bowman's capsule that filters the blood of its water and all of its dissolved nutrients, and then the functions of the proximal convoluted tubule and the distal convoluted tubule at drawing back many of those nutrients that are needed in the body. So also review the loop of Henle and the role that it plays in controlling the amount of dissolved solutes in that collecting fluid that will eventually spill over into the urine. So then when we look at the drugs that affect blood pressure and edema in the tissues, we considered aldosterone, a hormone which acts at the collecting ducts at controlling sodium and potassium reabsorption. So it was the potassium-sparing diuretics that worked here. There are various loop diuretics which, as the name suggests, block at the loop of Henle, and so they block that ability to reabsorb the sodium and potassium at the transporter that is a co-transporter for chlorides as well. Thiazides block at a transporter that transports sodium and chloride ions. So the thiazides tend to have their mode of action at the distal convoluted tubule. Note that it's at the proximal end of the distal convoluted tubule that this particular sodium chloride transporter is located, and that's where the thiazide diuretics work. We'll also talk about thiazide-like diuretics, drugs that aren't chemically related to the thiazides but also act at that proximal portion of the distal convoluted tubule. But it was the potassium-sparing diuretics that often needed to be taken in conjunction with either a thiazide or a thiazide-like diuretic, or in conjunction with a loop diuretic, because both of these tended to encourage the excretion of too much potassium. So the potassium-sparing diuretic blocked the actions at the collecting duct where there was an encouraged reabsorption of potassium, so that it spared the potassium from being excreted in the collecting duct and then disappearing in the urine. So we want you to revise the mode of action and the site of action of the thiazide and thiazide-like diuretics, the loop diuretics that clearly work at the loop of Henle as their site of action, and then the potassium-sparing diuretics. We want you to compare not only their mode of action, but any other nutrients or minerals whose excretion or reabsorption is affected at the nephron. One of the things that will control which drug your client is placed on might be known interactions that that diuretic has with other drugs, or perhaps any other adverse reactions or contraindications that that client may show. So we also want you to review the interactions, ADR, and contraindications, abbreviated to CI, or perhaps just cautions in the use of the various diuretics. So considering the thiazide diuretics and indapamide as a good example of a thiazide-like diuretic, recall that we said it was that proximal segment of the distal convoluted tubule where they act. They are very good at treating hypertension, but the thiazides tend to be less potent than loop diuretics and generally tend to have a longer half-life. They worked at a sodium chloride ion transporter, which was found at that proximal segment of the DCT, where they inhibit the absorption of the sodium and chloride back into the blood and encourage its excretion. The water then follows the sodium. But at the nephron, they'll also promote the excretion of potassium. The classic adverse effect then being the person will experience hypokalemia, an adverse drug reaction. Because they also encourage the excretion of magnesium, people may show a hypomagnesemia, an adverse effect to these thiazide-like diuretics. Because they encourage the excretion of uric acid, because they decrease the excretion of uric acid, the thiazides might lead to a hyperuricemia. So they could be used with caution in people that already had an existing gouty arthritis condition. They decrease the excretion of calcium and can therefore affect the muscles, either through magnesium levels or through disruption of calcium balance and electrolyte disturbance, and so there may also be muscle weakness involved with these thiazide and thiazide-like diuretics. But in addition, with any diuretic that's used to treat hypertension, one of the classic adverse drug reactions is just exaggeration of their mode of action. The person might experience hypotension and dizziness. Now, as you could guess, these thiazide and thiazide-like diuretics used with caution in people that have an existing renal disease or cirrhosis of the liver. When you look at the drugs with which they interact, any diuretic, but commonly the thiazide and indapamide, the thiazide-like diuretic, aggravate digoxin toxicity. So they decrease the amount of digoxin that will be excreted in the kidney. They also exaggerate and aggravate lithium toxicity because they will affect the levels of lithium that is reabsorbed at the kidneys. They also worsen a person who has hypoglycemia, and we'll see as a consequence that they are used with caution in a person that has perhaps a glucose intolerance, any kind of disorder, not necessarily diabetes mellitus, but any kind of glucose intolerance, or perhaps a person with alkalosis. Thiazides and non-steroidal anti-inflammatory drugs also interact to cause a blockage in the antihypertensive effects of the thiazide, because the non-steroidal anti-inflammatories themselves can lead to a hypertension via a different mechanism, but it blocks the antihypertensive effect of the diuretic. And as we also said, particularly if the person is on indapamide, that might affect their levels of uric acid in the person's blood, and that might decrease the clearance of uric acid, worsening a person's gout. In a similar way, we'll look at the loop diuretics, revisit the site of their action, and then look at, as a consequence of that, any other electrolytes or mineral ions whose absorption or excretion is affected. Then look at the adverse drug reactions and interactions, anywhere where that loop diuretic might be contraindicated or then used with caution. So, the loop diuretics work at the loop of Henle. Here, they are controlling the level of sodium that is reabsorbed, preventing this and encouraging the excretion of the sodium in that collecting fluid. They work at a sodium-potassium chloride transporter. As with the thiazide-like diuretics, they cause loss of potassium ions. They also decrease uric acid excretion. This will lead to higher levels of uric acid in the blood, and they inhibit the reabsorption of calcium and magnesium. So you can work out from that what sort of electrolyte disturbances might also happen as adverse effects if a person was on a loop diuretic. And oftentimes with the loop diuretics, the person needs to take a potassium-sparing diuretic at the same time to prevent the development of that hypokalemia. Certain people are at greater risk here, and it is people who have perhaps benign prostatic hypertrophy or who are pregnant, where loop diuretics are category C. They are used with great caution. They're used with great caution in people who have diabetes mellitus. The loop diuretics affect glucose levels in the blood and can aggravate diabetes mellitus. And similarly with the thiazide-like diuretics, loop diuretics might also then lead to an exaggeration of their mode of action, and the person could develop a low blood pressure. The potassium-sparing diuretics that worked at the aldosterone system in the nephron, where they antagonized by competitive means that action of aldosterone, block its action at the collecting ducts, and therefore decrease the amount of sodium that is reabsorbed. But they will increase the amount of potassium that is retained by blocking the excretion of potassium in that renal collecting fluid. They don't tend to have too many other effects at the nephron, only at that receptor for aldosterone where they block. They are very weak diuretics and often not used on their own for hypertension, only used to block that hypokalemia that is caused by the thiazide and thiazide-like diuretics and the loop diuretics. Potassium-sparing diuretics tend to be avoided in people who are on an ACE inhibitor or an angiotensin II antagonist. Here there is a great risk of retaining too much potassium, a hyperkalemia, and this electrolyte imbalance then upsetting the heart. A person who's on digoxin and lithium would also have levels of these drugs monitored while they were on a potassium-sparing diuretic. A person who then had an existing hyperkalemia would not take a potassium-sparing diuretic. This could be quite cardiotoxic for them, contraindicated if there is any pre-existing hyperkalemia. Also used with caution in people who have impotence or a history of headaches, and avoided in pregnancy. But there are other drugs that are used as hypertensives. It might be still a first-line therapy, or if the person has not responded to a diuretic antihypertensive, the person might then be trialled on beta blockers. We said we want a cardioselective beta blocker, one that won't have actions at beta-2 receptors in the respiratory system. So atenolol is one such cardioselective drug that blocks at beta-1 receptors. One particular brand name, tenormin, is this beta blocker antihypertensive. It inhibits not only the hormone adrenaline, but the neurotransmitter noradrenaline at that beta-1 adrenoreceptor, but dopamine also has various effects at this receptor too, and beta blockers will block those actions. This beta blockade does not affect the beta-2 receptors. We want, for antihypertensives, a cardioselective beta blocker. So what's happening here is the beta blocker, by acting at those receptors in the heart, will decrease the rate, the conduction velocity, and the contractility of the myocardial cells, thereby decreasing cardiac output. And this will then have that antihypertensive effect. Often though, when you decrease cardiac output, this can sometimes cause a reflex increase in peripheral vascular resistance, but beta blockers don't show this reflex action, so they're very good, great efficacy in some clients at controlling their hypertension. These beta blockers may also have some actions centrally in the vasomotor areas in the brain. They may also affect renin levels that are released by the kidneys, and as we'll see later, these beta-1 blockers also then indicated for various other disorders where there is a conduction problem through the heart. Conduction velocity tachyarrhythmias can be treated also with beta blockers. So one example given there, sotalol, which might also be used for treating hypertension or tachyarrhythmias. We'll see then that beta blockers can be used in a range of other cardiovascular disorders such as angina, in children, Fallot's tetralogy, a person who might have anxiety or hypothyroidism and experiences tremors or tachycardia might have these symptoms treated with a beta blocker. And as we said, beta blockers also used for cardiac arrhythmias and in myocardial infarct. In addition, beta blockers might be indicated for glaucoma, pheochromocytoma, a rare tumour of the adrenal glands, or people who are susceptible to vascular headaches. They are very efficacious in hypertension as a first or second line treatment, but they are contraindicated if a person already has an existing congestive cardiac failure or chronic obstructive pulmonary disease or diabetes. When used as antihypertensives, we stressed that it's important to go for a cardioselective drug, one that will have less adverse drug reactions on the respiratory system. There is only one beta blocker that is indicated for clients who have congestive cardiac failure, and that is carvedilol. It still controls the hypertension without worsening the edema due to that congestive cardiac failure by also affecting the output of the heart. So then to consider the antihypertensives that target the enzyme ACE. The drugs were the ACE inhibitors. They all ended in that OPRIL or APRIL. Some examples given there, as well as their commonest brand names that you will see in your clientele. So a person might be on captopril, an ACE inhibitor, sold as Capo-10, or enalapril, which is Renitec, or fosinapril, which is Monopril, the brand name. We stressed that all of these ACE inhibitors affect the production of a very potent vasoconstrictor. By blocking the enzyme that activates this potent vasoconstrictor, you get less constriction of arterioles and you get a great reduction in total peripheral resistance. People who are on an ACE inhibitor and a diuretic, there is, as we said, a synergism of action. If a person is already depleting their body of sodium, you get an intensification of the action of the ACE inhibitor. So a quite common combination therapy, a diuretic and an ACE inhibitor together. This then lowers the amount of the loop or the thiazide diuretic that might be used, and this might then improve potassium retention while the person is on that ACE inhibitor. So that person then wouldn't need a potassium sparing diuretic. The ACE inhibitor, with its synergistic action on hypertension, is sufficient to block that potassium depletion that the other diuretic often causes. But ACE inhibitors affect that enzyme ACE, particularly in the lungs where it is the most active. And here it also blocks the breakdown of bradykinin when that inhibiting drug blocks the action of the enzyme. More bradykinin builds up in that person's lung, and then this causes stimulation of receptors that feed back to the brain, instigating a cough reflex. So the person with hypertension takes the ACE inhibitor and then might develop this adverse drug reaction, a cough. The cough is not dose dependent. The person can develop after the first dose of the ACE inhibitor, and if seen and picked up early, best to take them off it, because that cough can persist for some time after the ACE inhibitor has been discontinued. This reflex cough that's produced might be seen in as many as a fifth of clients on ACE inhibitors, and tends to be more common in female clients. As with the other antihypertensives, ACE inhibitors might also be indicated for other reasons other than hypertension, so important that you know that and then question clients closely. They may be on this ACE inhibitor because they have a congestive heart failure or a left ventricular dysfunction after a myocardial infarct. ACE inhibitors can be used quite effectively in elderly people who also have diabetes. So this is a particular advantage of this particular therapeutic class in treating hypertension. Then we considered angiotensin II blockers or angiotensin II antagonists, and these all ended in that SARTAN. So we've given there some generic names so that you can see the consistent ending, and then some of the more common brand names that you may see among your clients when you question them as to what other medications they're on. So we have losartan, which is Cozar, irbesartan, which might be sold as Avapro or Carvia, candesartan, which is Atacand, and telmisartan, which is Mycardis, some very common antihypertensive drugs. So important that you can specifically describe the site and the mode of action of those angiotensin II blockers, that they are working at the blood vessels at the receptor for angiotensin II and competitively inhibiting the binding of angiotensin II. There are various receptor subtypes, and it is at the angiotensin type 1 receptor for angiotensin II that these drugs have their most potent blocking action. Because they're blocking the action on one of the most potent vasoconstrictors known, the drugs cause a smooth muscle relaxation, a vasodilation. But they also have other effects on salt and fluid excretion, encouraging the excretion of the salt, the water therefore following, and so they have effects on reducing plasma volume. We saw this because angiotensin II affects aldosterone action. So they block at the receptor rather than blocking at the enzyme that produces that most potent vasoconstrictor, the angiotensin II. They had their most potent action at the type 1 receptor. More importantly, because they don't block at the enzyme, you don't get an ACE inhibitor cough like you do with the ACE inhibitor drugs. So there's no effect on bradykinin levels in the lungs, whereas the ACE inhibitors inhibited the breakdown of bradykinin and led to greater levels of bradykinin in the lungs. Then lastly, we'll consider the calcium channel blockers and their use as antihypertensives. We will then go on and see later that they are also indicated for other cardiovascular disorders. They were a quite diverse class, so there was no consistent ending to their name. There are those that are dihydropyridines. These tend to end in dipene, such as felodipine and amlodipine. Felodipine sold as Plendil ER and amlodipine sold as Norvasc. But there are other calcium channel blockers that are phenylalkylamines, such as diltiazem, which is sold under the brand name Cardizem. Then there is a third chemical class, benzothiazepines, such as verapamil, which is sold under the brand name Isoptin SR. So all of these calcium channel blockers used to treat essential hypertension, also used for a person who has a chronic stable angina, and verapamil can be used as an antiarrhythmic because the benzothiazepines also have an action on the conduction velocity in the heart. All of the calcium channel blockers competitively block the re-entry of calcium ions into cells so that there is less calcium available for continued excitation contraction. Because there is less contraction, this leads to a relaxing effect on vascular smooth muscle, therefore lowering blood pressure. You get overall a vasodilatory effect from the calcium channel blockers, and because of this vasodilation, an action at total peripheral resistance, where resistance is lowered, and this is what then lowers the blood pressure. This mechanism is particularly demonstrated by the dihydropyridines, the ones that end in dipene, such as felodipine. But all the calcium channel blockers also decrease the contractility, which was the inotropic effect, by affecting the cardiac muscle contraction, the force of the beat, but also the length of the muscle contraction. This is another way that they then affect blood pressure by targeting cardiac output. A lower force of contraction and reduced length of contraction, a smaller cardiac output, therefore a lower blood pressure. But because of this lower cardiac output, these calcium channel blockers are contraindicated in people that have an existing cardiovascular disorder that is of the congestive cardiac failure type. Then we said we'll briefly consider drugs that work at the alpha-1 receptor, where they once again act as antagonists, blocking the effects of adrenaline at that alpha-1 receptor, also blocking the effects of noradrenaline and any sympathetic controls to cause that higher blood pressure. So the alpha-1 receptor mediated vasoconstriction. The alpha blocking drugs therefore lead to a vasodilation. That vasodilation reduced the total peripheral resistance, this time on the arterial side. It was important that any change in total peripheral resistance affected cardiac output, and we saw that changes in cardiac output can cause reflex changes on total peripheral resistance. But if you control total peripheral resistance on the arterial side only, this puts a reduced afterload on the heart. You get a reduced venous return, and this produces a bonus reduction on the preload on the heart, a decreased cardiac output. So the alpha-1 adrenergic antagonists actually worked by two actions on both total peripheral resistance and cardiac output. So drugs like prazosin, very potent as antihypertensives. So they're the choice that's used for a person who might have a hypertension that was resistant to other drug treatments. In addition, though, it might be used to relieve urinary obstruction in benign prostatic hypertension, or a person who might have both disorders, generally an elderly male who has the benign prostatic hypertension, who might also have high blood pressure, where prazosin might be the drug of choice. These alpha-1 adrenergic blockers also can treat problems where a person might have a reflex tachycardia if they took a vasodilator, whereas if they were at risk of these reflex tachycardias if they were on prazosin, they don't tend to show this same reflex tachycardia, because as we saw, the alpha-1 antagonists just work on the preload effects because of a reduced afterload effect. But as with any antihypertensive, they can lead to an exaggeration of that action, and the commonest adverse effects seen with the alpha-1 adrenergic antagonists are postural hypotension. After the first dose, the person might show this effect, so you will know very early if this is going to be a particular problem for them. So this is where, when changing position, perhaps from lying down to sitting, or from sitting to standing, the person experiences a quite severe hypertension, a change in blood position leads to quite a dramatic drop in their blood pressure, also known as orthostatic hypotension. The person might also just develop dizziness after the first dose with an alpha-1 adrenergic antagonist. So we've considered the many ways that hypertension is treated. It was most important that lifestyle changes be incorporated in that treatment at all levels. Initially, because some people will respond to these lifestyle changes, but if it is an essential hypertension where there is some dysfunction somewhere in the many body systems that control blood pressure, the person might be put on a first-line therapy, a diuretic. We saw that might be a thiazide-like or thiazide diuretics, or a loop diuretic, where they might also need a potassium-sparing diuretic to block the hypokalemia. If that hypertension did not respond to the diuretics, the person might be tried on a beta blocker, or they might be on a thiazide diuretic with an ACE inhibitor as a way of controlling potassium depletion. Angiotensin II receptor antagonists were another type of antihypertensive, where instead of blocking at the enzyme that produces angiotensin II, the most potent vasoconstrictor known, it blocks at the receptor for that vasoconstrictor, therefore leading to the vasodilation that mediates the decrease in blood pressure. The advantage here with the angiotensin II receptor antagonists, you didn't develop the same cough that quite a high percentage of people on ACE inhibitors will develop. So then we considered calcium channel blockers, alpha blockers, then ones that dilate at blood vessels, particularly arterioles, such as hydralazine, and we saw that there were also various centrally acting drugs that can block the effect of vasoconstriction at the blood vessels and then lead to vasodilation and blocking hypertension.